for covering that so elegantly. I'll now ask Dr. Shamira to talk to us about the importance of 24-hour IOP control. Over to you, Shamira. Shamira, can you just unmute yourself?
Hi there, can you hear me?
Yeah, we can hear you. We can see your slides.
Okay, excellent. Thank you very much. Thank you very much, Ronnie, for the kind introduction, and Shibal for doing a fantastic piece on that. I mean, I'm going to have to steal one of your phrases, that glaucoma has no symptoms until we start treatment. I'll obviously reference you for that, but it's a great line, and it's a very important relevance to what I'm going to be talking about here. So I'll be speaking about the importance of 24-hour IOP control. And these are my financial disclosures, some of which are relevant to the talk today. Now, I wanted to go and really talk about how we can look at IOP in a different light. And it's all about quality rather than the actual numbers. And it's a holistic approach, which is something that Shiba was espousing just right now. And we know when we talk about the quality of IOP control, we're not just talking about the mean IOP reduction, but we're talking about other things like the response rate. And we're talking about the long-term IOP control and visual field stability, because that's what's the thing that's important to patients, at the end of the day. And these are the patient-related outcome measures that we should be looking at. Another factor that's come out recently as important is the 24-hour fluctuations, and I'll be going into that into a lot of detail. Shiva was talking to you earlier on about the patient adherence and compliance and persistence, which are all important factors for maintaining that quality of IOP control. Just to give you an idea of what that actually means, there was a little study done by Hughes and colleagues, which looked at the 24-hour monitoring of patients. And they found that when you look at the mean IOP in office and as a 24-hour IOP, you could see there was not much of a change, but there was a slight change in the mean IOP. And when you looked at peak IOPs, you found that actually in office was really not so good as looking at the 24-hour IOPs. And the difference in these values ranged up to 12 millimeters of mercury. In fact, you'd be changing your clinical management in almost 80% of patients if you only knew what the 24-hour IOPs were. So they found that actually in this study that when you looked at the peak IOPs over a 24-hour period, they were actually almost 5 millimeters mercury higher than those in the office IOPs. And the actual peak of these IOPs occurred outside normal office hours in roughly half of those patients. In another study, looking at the importance of looking at home IOPs as well as the office IOPs, these patients had home tonometry measurements done, and you could see that in the first picture here on the left, when you look at the office IOPs, when you compare the rate of progression, when you look at the highest office IOPs and the lowest office IOPs, there's not much difference. So in actual fact, what you're seeing here is actually that it seems like there's no real big deal about measuring the office IOPs. But actually, when you look at the home IOP range, you can find that after the 8-year time point, when you look at the lowest 25% of those with the range of IOPs, you can see that there are 43% not progressing. Whereas when you find in the other group, the ones with the highest 25% of the IOP range, they find that there are 12% that have no further progression. So that you can see that actually it's very important to look at the home IOP ranges. We looked at this diurnal fluctuation in angle closure. It's one of the very few studies that have been done in angle closure. So here we looked at patients over a 24-hour period, and we looked at their range of IOPs, and we looked at the different time points during the day. We found that in PACS normal, the IOPs were much lower than the other groups, and that their fluctuation was not so much. Now, when you looked at the PAC and PACG groups, the mean IOP was higher, but of course, the fluctuation was highest in the PACG group. So of course, it seems to be that the fluctuation leads to glaucoma. Now, how does this happen? Well, it could be from a number of reasons. Firstly, from instantaneous fluctuations in things like the natural changes in IOP secondary to homeostasis. So, for example, when you do things like drink a lot of water, you can see a sudden increase in IOP. And this has been purported to be a useful test in some situations at looking at the usefulness of the trabecular meshwork to absorb IOP spikes. When you look at different positions, you can see that in the lying position, we've been susceptible to higher increases in IOP, and the laterality of the position also may play an effect as well. There are these various autoregulatory mechanisms in aqueous hemodynamics that are thought to be behind this phenomenon. And actually, these diurnal spikes and troughs in IOP have been found to be present in normal patients and also glaucoma patients over 24 hours. Now, how do we measure these 24-hour IOPs? Well, this is one example. This is the Triggerfish from Sensimed. And what you can see here is a very, very sophisticated device. It's a contact lens sensor for IOP. And you place it on one eye, you close the eye, you pad it up, and there's wires that come out around the side into a battery pack that's placed around the patient's waist. Now, it's very expensive. It's about 500 euros per shot, and it only measures it over 24 hours. But what it gives you is a good measure of what's happening to the pressures inside the eye. Now, it doesn't give you in IOP, it gives you in millivolts equivalent. So that's what you see on the y-axis, and on the x-axis, you can see the time. Now, as you can see in these different groups, the blue, green, and red groups, they're quite different. So the blue group is the healthy group. And compared to the others, you can see that actually, when you look at the fluctuations of IOP, compared to healthy eyes, patients with glaucoma have earlier IOP peaks, higher values in the IOP peaks, and prolonged peaks. And the diurnal IOP profile was poorly correlated with nocturnal IOP profile. Now, when you look at this other study, this was a study that was done on eyes that have had about 8 visual field tests done. And they looked at the IOP during 3-hour periods from 9 a.m. All the way through to 9 p.m., 24-hour period. And when they looked at this, they found that actually they were measuring the IOPs during the daytime with the normal pneumatometer, so with normal GAT, and during the nighttime supine with a pneumatometer. And what they found was that actually the worst visual field was associated with higher 24-hour IOP peaks and also greater fluctuation as defined by the range of IOP values. So again, in this group that were NTG patients, we're finding that the peaks make a difference and the fluctuation makes a difference. And this actually is borne out in our clinical practice. We find that fluctuation is more important in those patients where there are lower IOPs. Where you've got POAGs and PACGs, for example, with very, very high IOPs, the fluctuation is not so important. But in the lower IOPs, then the fluctuation becomes a much more important factor. In another study that looked at 24-hour IOP fluctuations and glaucoma progression in 240 eyes of 120 patients, you could see that when the patient was awake, the key factor was the number of large IOP peaks, and that led to greater visual field progression. However, when the patient was asleep, you found that the key factor was the mean IOP peak ratio. Now, what that means is that a high peak ratio is where somebody has a large peak that occur at a higher speed, in other words, a higher acceleration. And this is well known to be a cause of greater damage on the biomechanic level to the optic nerve head, and this is what causes the progression. Now, moving on, when you look at the cases of these 24-hour IOP fluctuations and glaucoma progression, the other factor here that we're looking at is short-term IOP fluctuation. And these have caused not only an increase in the visual field defects, but also increase in the cup area, so a structural defect on optic nerve imaging. Now, how does this impact us on a practical level? Of course, we know that some of these tests are not really very practical unless you've got a lot of facilities and the wherewithal to conduct these quite intricate testing, and of course expensive as well. So I would suggest that, whenever you have the opportunity, do some kind of phasing, whatever means necessary you can. Ideally, it would be with a appellation tonometry, but of course, if the only method available to you is with a tonopen or with an airpuff, that is also still useful, because we look at things like the 24-hour range of IOPs and the difference between both eyes as well. In this study, this was done by Professor Constas, who is an expert at doing these crossover studies. He did a prospective observer masked crossover study looking at patients with open-angle glaucoma, and they were randomized to receive either preservative-free tafloprost or preserved latanoprost. Now, what they found was that there were two important findings from the study. Number one, the tafloprost demonstrated a greater mean 24 IOP reduction against the latanoprost. So in other words, the mean was lower in the tafloprost compared to the latanoprost. And secondarily, they also found the fluctuation was also more limited in the tafloprost group. So this is also an extra benefit as well. The primary endpoint was the mean 24 IOP, but the secondary endpoint was the fluctuation. So again, you can see how tafloprost in this study shows a beneficial effect against latanoprost. So to summarize, I'll say that IOP fluctuation is really underused and underestimated, and it should be utilized more by us, especially in the cases of normal tension glaucoma. We should use the peak IOPs from phasing and initial diagnosis to guide our treatment, to look at what kind of target IOPs are strive for in the longer term future. But of course, that's a talk for another day. Now, monitoring, as we've seen here, is difficult at the moment, is expensive and cumbersome. But of course, this area is set to grow. And imagine the differential change in our management when we have all this extra information. I'm sure it's a big growth area for the future. So thank you very much for asking me to speak today. And I hope this would hopefully change your management and make you understand about the differences that glaucoma specialists look at IOP fluctuations and peak values and mean values compared to the other ophthalmologists. And hopefully you can incorporate this in your practice very soon. Thank you very much.
Thank you, Shamira, for covering that so simply and making things very clear.